In this Pearlcast, we're going to talk about pre-implantation genetic screening, commonly known as PGS. PGS is done after IVF creates embryos, and it's a biopsy of cells on a day 5 blastocyst. If you'll remember from our previous IVF discussion, the day 5 blastocyst under the microscope has what's called an inner cell mass, which will become the fetus, and then it has trophectoderm cells, which will essentially become the placenta. In PGS, a biopsy with a very fine needle is done of a few of these cells, typically 5 to 10 of these trophectoderm cells, leaving the inner cell mass alone. These cells are then analyzed for their chromosome makeup or their karyotype. We want to know what the karyotype is of this blastocyst to hopefully ensure pregnancy success. In the karyotype, we're simply looking at the number of chromosomes, and you'll remember 46 is the correct number, and then obviously we will know if it's male or female, XY being male, XX being female, obviously. So why is PGS done? Who do we offer PGS to? Currently there are 4 criteria that we offer PGS to couples. The first is recurrent pregnancy loss. Has the couple had 2 or more early pregnancy losses in their road to trying to achieve a pregnancy? The second is repeated IVF failure. Have they gone through a number of IVF cycles, be it fresh cycles or frozen cycles, and they still haven't achieved a pregnancy, or maybe they've had a chemical pregnancy that wasn't viable? A third possibility is severe male factor infertility. When we do a semen analysis on the male side of the couple, we look at the different parameters and just how severe is that male factor that could be contributing to abnormal embryos. And then the fourth is advanced maternal age. So this is when the female is greater than or equal to 35 years old. The reason we have these criteria is because we know in a number of times, and if they fit one of these criteria, there can be abnormal chromosome arrangement leading to abnormal embryos. What you have to remember is that anybody coming to a fertility specialist and creating embryos through IVF, at least 40% of the embryos are going to be abnormal and never make a pregnancy. If they fall into one of those criteria of the PGS that I just mentioned, this number could be even higher than 40%, and thus dooming them for repeated failures if we don't know the chromosome makeup of the embryos themselves. Let me explain why PGS is important with a patient scenario. Say you have a 30-year-old female who has had recurrent pregnancy loss. She and her husband have gotten pregnant, but they've had 2 or 3 losses between 6 and 10 weeks gestation and had subsequent miscarriages. When they come to a fertility specialist and they're going to do IVF, we offer them PGS, because we want to know, is there a reason they're having these losses at 6 to 10 weeks based on their embryo makeup? So there is a patient who I have seen who's 30 years old. She went through IVF. We got 40 eggs at the time of egg retrieval. Of those 40, 22 were mature. Of those 22 that were trying to be fertilized, 15 fertilized. Of the 15, there were 7 day 5 blastocysts that were biopsied. Of these 7, 3 had normal karyotypes. So what started in a 30-year-old young healthy female getting 40 eggs, at the end of the day we were down to 3 normal embryos. If you remember from my IVF overview, this illustrates the idea of this IVF attrition exceedingly well. However, we were able to transfer one of these embryos, and she achieved a pregnancy that way and has 2 normal embryos still frozen. Let me illustrate it another way. Another criteria, in addition to the recurrent pregnancy loss we just went over, another criteria for PGS was the advanced maternal age, or AMA. We have a patient who's 42 years old and she wants to do IVF. She chooses to do PGS. In her, we also got close to 40 eggs at the time of retrieval. We got 39. Of those 39, I won't go through every step, but she actually had 15 blasts or blastocysts that were able to be biopsied with PGS. Of the 15 blastocysts on day 5, she had 4 normal embryos based on their karyotype. So that's 11 embryos that were abnormal based on their chromosome makeup and would never go on to make a pregnancy. Both these patient scenarios illustrate the point that with increasing technology that we have, we feel that embryo makeup of the chromosomes is very important to a number of fertility and pregnancy issues. And this is why we have the 4 criteria for the PGS. So what are the benefits of PGS, of this relatively new technology? Well, obviously with IVF, it's driven by success rates. One benefit of PGS is hopefully you're going to increase that success rate of pregnancy with IVF. The second, and a big concern for IVF, is multiple gestation. Well, if you have PGS done on the embryos and you know that they have a normal chromosomal complement, you can transfer one embryo and hopefully decrease multiple rates. This is what's called an elective single embryo transfer. A third point is decrease in embryo storage or wastage. And what I mean by that is, I already told you that at least 40% of embryos created are abnormal and never going to go on to make a pregnancy. Well, without PGS, we don't know that, so we go ahead and freeze those embryos. Now, there are hundreds of thousands, if not millions, of embryos stored worldwide, and if we can get those down to number of stored embryos being the most competent embryos, that number theoretically would almost be cut in half. And then another potential benefit is simply give the patient or the couple answers as to what's going on and why they're having such difficulty either with the recurrent pregnancy loss or recurrent IVF failure. Maybe they are in a subset of folks that are making poor quality embryos, and hopefully through PGS we can choose that right embryo to do the transfer and have that success for them. So in conclusion, for a PGS overview, there's certain points you need to remember. The first and foremost is the fact that in nature, as well as in IVF cycles, humans, a large percentage of the time, make abnormal embryos based on the number of chromosomes or the karyotype. This probably speaks to why we have recurrent pregnancy loss and early miscarriage rates at a decent percent of the time as well, and hopefully we can overcome that with this PGS. Second point of PGS is it's a biopsy. It's a biopsy of troph ectoderm cells of the day 5 blastocyst. And remember, the troph ectoderm aren't the cells that go on typically to go on to make the fetus, so it's theoretically safe as well. The third is simply increasing IVF success for a pregnancy. If we know we're transferring competent and normal karyotype embryos, we have to believe that there's going to be an increased pregnancy rate with those. The last, and perhaps one of the most important ones, is something called elective single embryo transfer that we talked about. And this will further decrease the rate of multiple gestations. That is a goal of IVF moving forward, not only to increase the success rate, but at the same time hopefully decrease the multiple rate, because multiple pregnancy has complications not only for the mother but obviously the babies as well.